From training to performing, join our big league conversation. Welcome to the CSP Elite Baseball Development Podcast with your host, Eric Cressey.
Welcome back to the CSP Elite Baseball Development Podcast. I'm your host, Eric Cressey, and this is episode 77. We're going to be continuing with our sports medicine themed series of episodes here. We've got an awesome orthopedic surgeon on as our guest. And what I really like about him is that he's not just a guy who's seeing patients and doing surgeries, but in reality, he's actually very involved on the research side of things on a number of fronts. One, to help prevent injuries. Two, to really help track and classify injuries and understand return to play timelines and how to make people more successful after they do get hurt. And I think also he's a teacher, so he's doing a good job of trying to figure out better surgical techniques and ways to impact the next generation of sports medicine professionals. So this is a really good episode, and what I like about it also is that, you know, it's a good opportunity to kind of like meet in the middle between the strength and conditioning world and the sports medicine world. So we had some good dialogue here, and I actually learned a lot as we took this deep dive into his world, and I think you will too. Overuse injuries have emerged as one of the biggest threats to players at every level of competition. As an example, at the professional level, ulnar collateral ligament injuries at the elbow alone sideline pitchers for an average of over 17 months. That's a ton of lost development and a threat to lengthy careers. Just as concerningly though, for youth players, overuse is the predominant mechanism of injury. So what can be done? Obviously, we need to train athletes to be prepared for all the stresses the game throws at them. However, the other side of the equation, recovery, often doesn't get the attention it deserves. Healthy, recovered arms mean you can stay in the game and give your best on the field, and that's where Mark Pro comes in. Mark Pro is a cutting-edge recovery tool that provides all the benefits of active recovery, but without the extra effort, muscular fatigue, or stress to tendons and joints. Players can use Mark Pro as long as needed for exceptional recovery between training sessions or after games. We'll often send Mark Pro units back with athletes to their hotels or even have them use them on team flights. Both easy to use and portable, Mark Pro is a powerful tool that allows recovery anywhere, anytime. Use it while relaxing at home, on the road, or during tournaments. On a personal note, I was originally a naysayer when it came to Mark Pro. However, longtime Cressey sports performance athlete Corey Kluber turned me on to it. He adopted Mark Pro into his post-pitching recovery approach, and it was an integral part of him going out and throwing 200 innings year after year. This led me to experiment with it myself and with more of our athletes, and the feedback was consistently outstanding. Now, just a few years later, you'll see it in every major league organization as part of the routines of some of the most accomplished baseball players on the planet. If you're looking for the same results enjoyed by these athletes, visit markpro.com and use the coupon code Cressey at checkout for an exclusive discount. Again, that's markpro.com, markpro.com, and use the coupon code Cressey, Cressey, at checkout for an exclusive discount. Today's guest completed his undergraduate studies at Lee University and then went to medical school and his orthopedic surgery residency at the Mayo Clinic College of Medicine. He subsequently completed a fellowship in research and clinical orthopedic surgery sports medicine at the Hospital for Special Surgery. He returned to the Mayo Clinic to serve as orthopedic surgeon and assistant professor of orthopedics. In 2019, he was named medical director, team physician, and director of high performance for the Minnesota Twins. He conducts clinical and basic science research on injuries of the shoulder, elbow, and knee, and he studies biomechanics of the throwing motion, injuries in overhead throwing athletes, and epidemiology of injuries in professional baseball and other sports-related injuries. Many of his research efforts focus on injury prevention, improving surgical techniques, and optimizing return to play times. If you head to PubMed right now, you'll actually find his name as the lead author or co-author on 169 scholarly journal publications. So he's a very prolific researcher and a great clinician. Please welcome to the show, Dr. Christopher Camp. Welcome to the show, Christopher.
Thanks so much for having me, Eric. Really appreciate it.
No sweat. I'm excited to do this. I have followed your work from afar in the research realm, but I also know you're a day-to-day clinician who sees a lot of overhead athletes on a regular basis. So we're excited to delve into both the research background and the clinical expertise. So I'm gonna kind of start there. I think one of the things I would say is we have a broad collection of folks that listen to this podcast, right? We have, basically the parents and kids that listen to it on the way to the games. We have the coaches that listen to it, but we also have a really strong, collection of sports medicine professionals, ranging from strength and conditioning coaches up to athletic trainers and PTs and even, orthos that have kind of checked in on this. So I want to make sure that we have something for the sports medicine crew. And I think a good place to start is maybe in respect to the injury reporting research that you've done. So we've had Stan Connie on the podcast recently, and I know you guys have collaborated some, and your work at times has been in the same vein, reporting on what's happening with injuries that we're seeing in the baseball community, at the MLB level, but also younger. So I'm curious, starting on that front, what trends are you seeing at the professional levels that you feel might be concerning? Where are we headed?
Yeah, great question, Eric. And yeah, you're right. I know Stan well, and he and I have worked together and collaborated quite a bit. And before I answer this question, one of the things I will say is one of the things that I think we have gotten significantly better at in the last few years is tracking injuries. We have much better systems now for recording and reporting injuries than what we had even 10 years ago. Mm-hmm. So we feel like our data and information is much more reliable. And having this over the last few years has really allowed us to take a deep dive into some of these injuries and trends. One of the things that we've seen in the last probably 10 to 15 years is that there is some good news. Shoulder injuries in pitchers are actually on the decline, which is good. It's not a dramatic decline, but there is a slight decline for that. So that's good news. The bad news is that is being met with a reciprocal increase in elbow injuries. Mm-hmm. So the elbow is getting a lot of attention recently, and rightfully so. And obviously, the big one for the elbow that we all talk about and worry about is the Tommy John injury, which is a rupture of the medial ulnar collateral ligament of the elbow. And so that's one of the ones that gets a lot of press, a lot of publicity, and a lot of our attention. Mm-hmm. Now, surprisingly, it is not the most common injury in professional baseball. Mm-hmm. In fact, when we looked at it, we did a study looking at about 50,000 injuries in professional baseball. And it came out as number 5 or number 6 on the most common injuries. Mm-hmm. However, it is the one that ends up resulting in the most time out of play, since the vast majority of them end up requiring surgery at the professional level. So that's why it gets a lot of attention. It's not necessarily because it's the most common, but when it happens, it can potentially be devastating. So a couple of the trends that we've noticed with that one, specifically, one is that when we reviewed sort of all the Tommy John injuries that have happened since mid 70s, when Tommy John had his first one, all the way up until the year 2018, we found that within the last 3 to 4 years, the number of Tommy John injuries in Major League Baseball players is actually decreasing. Mm-hmm. So that was great. We were excited, very, very happy to see that. Unfortunately, when we looked at the minor league side, we saw that it was increasing dramatically in the minor league side. So although we initially were optimistic and thought, well, maybe we're actually making a dent in this and we're reducing injuries, it turns out we're not really reducing the injuries. They're just shifting to younger players. Mm-hmm. So now what we're seeing is the injuries are continuing to rise, and they're happening more commonly in younger players and minor leaguers rather than the older major leaguers.
That's an interesting observation, and definitely something, I think clinically that aligns with what we're seeing anecdotally. And actually, as you went through that, 2 questions popped in my mind. So we had Dr. Chris Ahmad on previously, and one of the things that we mm-hmm. touched on was that a lot of these younger guys who at 21, 22, as they're getting their minor league careers going, who are, injuring their UCL, a lot of those guys are going into surgery, and, they're presenting as guys who previously had lower grade injuries that maybe calcified over, and then those injuries reach threshold. Is that something that you're seeing when you see a 23-year-old minor leaguer that comes in? Are those ligaments dinged up previously before you actually do that UCL reconstruction?
It's a mix, to be honest with you, Eric. So we see some that come in having been previously healthy, and then all of a sudden have an acute injury that's new. Mm-hmm. But just like Dr. Ahmad said, more commonly we are seeing injuries that have had some chronic attrition or degeneration over the years. Mm-hmm. And the athlete was sort of able to compensate, able to keep up, and then eventually they reached a point where they just couldn't keep up anymore, and the ligament fully ruptured or tore. So yeah, I agree completely. We're certainly seeing that.
I think we're realizing it as an industry, like we kind of need to slow cook our teenage pitchers. We don't need to chase 95 at age 14, but if it happens at 18 after a steady linear progression over the course of years, they seem to do better long term. The second side of that, you mentioned fewer shoulder surgeries. So what I'm curious about is, are we seeing fewer shoulder surgeries at these highest levels because we're realizing that it's a lot harder to come back from shoulder surgeries than maybe we did 10 years ago, and so we're recommending them less? Or do you think it has actually something to do with the care that they're receiving from a proactive sports medicine standpoint?
Yeah, fortunately, I actually think it's the latter. I think it is more the injury prevention measures, because even in the data that we looked at that I was quoting is not just looking at surgeries, but it's looking at actual injuries. So yes, you're right. Shoulder injuries are less commonly getting surgery because the outcomes are not great, but we are also seeing slightly lower numbers of shoulder injuries in and of themselves. And I think that's probably because if you look back, within the last probably 15 years or so, there's been a real increased emphasis on scapular mechanics and scapular stabilization and those types of things, which I think is sort of the link in the chain before the shoulder. And I think we've had a lot of focus on that area, and you got to wonder if maybe us improving that and focusing on that and developing good shoulder stabilization programs for these guys has maybe helped a little bit with the shoulder. Now we just need to sort of transfer that same thing down to the elbow if we can.
Do you think when we're doing these evaluations of a shoulder from an injury, I guess, counting standpoint, are we mixing the thoracic outlet cases, the lat strains in there? Are we talking purely glenohumeral joint? How do you kind of define the scope of that collection of data?
Yeah, so we've looked at it in several ways. So if we lump them all together, it is going down. But yes, if we look specifically at different types of injuries, you will see some noise in there where some of the specific shoulder injuries are going up, some of them are going down. Overall, the average is trending down slightly. Again, it's not dramatic, but it's slight. But if you look at specific injuries, you may see some changes. And thoracic outlet has certainly been one of them that has been increasing, which I think is probably more related to our understanding of it. We've started to understand it and identify it more commonly. And I would imagine if we look back probably 10, 15, 20 years ago, there were some guys that had it and we didn't really understand exactly what it was. And it was much harder to make that diagnosis then than it is now.
Absolutely. So switching gears or maybe progressing gears a little bit, what about the youth levels? Do you feel that, we're making progress? Obviously, we've seen nationwide pitch counts, integrated in all states. We've seen more outreach to the youth communities with respect to arm care programs to kind of offset the outreach in terms of really aggressive throwing programs early. Are we making progress, or do you think the trends are still headed in the wrong direction from the youth sports standpoint?
Yeah, I think if we look at all of the sort of the epidemiologic studies, and again, I have to admit, we don't have as good of data on our youth players as we do the professional athletes. Obviously, just because there's so many of them and they're spread out, it's harder to keep track of. The few epidemiologic studies we do have on youth players actually suggest that their rates of injuries are growing faster than the professional athletes. Which is unfortunate, but there is so that's sort of the negative. On the brighter, more optimistic side, there is some good evidence showing that players, parents, and coaches are becoming more aware of this. They're becoming more aware of the value and the importance of pitch counts. There are compliance issues, certainly, but it does seem to be improving slightly. And there's also been some studies that have shown that arm care programs for youth athletes reduce injury rates. And so we have some good evidence to support some of the things that we've suspected. Now we just have to continue to work hard to get that message out and try to roll it out to the masses, which is very difficult to do.
I think the other thing that's great about that message is I think there's assumption, unfortunately, in the training community that training for health and training for performance are mutually exclusive things. And I think we have research that also shows that those arm care programs don't just help keep kids healthy. In many cases, they add velocity. You're teaching somebody more efficiently to transfer forces. And I think as an industry, people like to sell out for the sexiest training approach, right? They want to get on the aggressive throwing program when sometimes it's, get in the weight room, get strong in the right places, work on single leg balance, get your arm care where it needs to be, throw the med ball. There are all these other ways from a maybe a slightly less specific standpoint that we can grow, general athlete potential before we really sell out for those specific initiatives.
Absolutely. And honestly, I think that is probably, we have to sort of capitalize on that fact that, yes, not only can these programs make you healthier and increase the length of your career, reduce your injury risk, but they can also make you better.
Yeah.
And the issue is, and we've seen this, Eric, with ACL prevention programs. So we know that if athletes, and this is most common sort of in soccer, basketball players where ACL injuries are very common. If athletes will do an ACL prevention program, it can reduce the rates of ACL injuries by up to 50% in some populations and even 75 in some of the highest risk populations, which is pretty dramatic.
Oh, no doubt.
And what we've seen in years past is that we can show that data to, let's say, a high school soccer team. We can show them that data, and it resonates with them because they've had a couple of players that have had ACL injuries the last few years, so it hits home. So they'll buy into the program, do it for a few years, number of ACL injuries drops, and then all of a sudden it sort of loses that momentum or sting because they think, well, why are we doing this program? We haven't really had any injuries. Are we wasting our time?
Yep.
And then they stop doing it. The ACL injuries come back. Then they're motivated again to do it. So we sort of have this, up and down effect of these things. So it's really hard to sell these programs if you do it purely on the basis of injury prevention. So I agree with you. I think one of the keys is we have to let people know, yes, it'll reduce your injury. It can also increase your career length and make you a better athlete and a better thrower. I think that's really important in the messaging.
No doubt. And so I'm actually intrigued. Maybe this is more of like a personal reflection for you. I'll never forget the first time I saw a 12-year-old walk in with a UCL tear, and the referring, physician didn't want to do surgery because there were still open growth plates. It was too early on. Are you actually seeing that young athletes that are coming your way they're effectively outpacing sports medicine's ability to keep up with them in terms of not just diagnosis, but more importantly, probably the treatment? Is that becoming an issue in your eyes?
It is, and that's sort of across all of youth sports. That's not a baseball specific thing. We're seeing that with multiple injuries, shoulder dislocations, ACL tears, Tommy John injuries, cartilage injuries, all of those sort of things. And these are happening in younger and younger athletes, which is a very concerning trend.
That is. So we'll dig in on elbows a little bit further. Some of your research has reported on different methods for UCL reconstruction in terms of both surgical approach, the graft site utilized, whether or not to do an ulnar nerve transposition concurrently. What lessons have you learned in your research that you can share for, hey, there's a kid that's on this line right now who is 19 years old, who's a week out from Tommy John surgery, and he's trying to pick his surgeon. What are some of the things that you've learned?
Yeah, I love this question, Eric. And this is one of the things that sort of keeps me up at night thinking about. And just to give you some background on sort of why I'm interested in this, if we think about, the medial ulnar collateral ligament of the elbow is a relatively small ligament compared to the rest of the ligaments in our body. We reconstruct this, and it often, on average, takes a pitcher 12 to 16 months to get back to their previous level of play and their previous form. Let's contrast that to a multi-ligament knee injury in an NFL player. So there was a great study that was published in Sports Health looking at NFL players who tore at least 2 and up to 3 or 4 ligaments in their knee. Had them reconstructed. Their average return to play to football was less than a year. And some were getting back in as fast as 9 months. And I have to stop and think, wow, if a football player can get back to football after a multiple ligament knee injury in less than 9 to 12 months, why is it taking us so long to get some of these guys back after UCL reconstruction? And I think there are several reasons. One of them is obviously we have to optimize the rehab program, which is one avenue of interest of mine, which a lot of work has been done. But the other is the surgical technique. And generally speaking, across the rest of the human body, when we have tried to develop techniques for repairing or reconstructing ligaments, we have found that generally they do best when we design a reconstruction that tries to mimic the normal anatomy. So right now, the most common techniques that we use for Tommy John reconstruction, they partially mimic the normal anatomy, but they do change the biomechanics of the elbow slightly. And so, in my personal opinion, is I think that we still have some room for improvement in the surgical technique. And so, we've got a technique that we've been working on that's a more anatomic approach. It's still in the early stages, but has shown some very promising improvement and recovery and allowing pitchers to get back a little bit sooner. So there are still some things and tweaks that we want to be doing, and it involves things like changing the graft construct, so how we fix it to the bone, where we fix it to the bone, augmenting the reconstruction using either suture tape or internal brace. People have heard a lot about that.
Yeah.
Adding biologic agents, whether it be stem cells, PRP, those types of things to speed up healing. Mm-hmm. And then also having a good idea of which ligaments can be repaired versus reconstructed. Yep. And just for the audience, the difference there for us. So a repair is when you keep the ligament, you just sew it back down. A reconstruction is when you put a new ligament in. And generally speaking, the repairs for players that are eligible for the repair tend to get back a little bit quicker. They're usually on that sort of 6 to 9 month range, whereas the reconstructions typically take a year or longer. So obviously, if somebody is a candidate for a repair, it would be best if we could do that repair on them, because that may save them 3 to 6 months. So we're working on sort of fine tuning who is an appropriate candidate for which procedure as well.
Do you think, some of the differences between ACL and UCL? I mean, obviously, it's anatomical, right? Your knee is a larger joint than an elbow. Mm-hmm. Like, do you think part of the concerns with specifically replicating the normal anatomy is just that medial epicondyle is so much smaller than what you're dealing with at the knee? Like, I know there's always concerns about medial epicondyle fractures coming back, and you'll see those here and there on post-op Tommy Johns. You very rarely hear about that stuff with an ACL, correct?
Correct. Yeah, you're exactly right. And that's because, on the knee, you get the femur and the tibia, which are both huge bones, mm-hmm. which open up a lot of different options for fixation methods. Yep. So we use different types of screws, buttons. We have all of these options available to us just because the bones are so large and it's very easy to work with. In the elbow, it's much smaller. You have a lot less real estate to try to fix these grafts down to the bone. But fortunately, our technology has advanced too. So we have some anchors that are in different fixation methods that are available to us now that weren't available to us 5 years ago. And I think that this is sort of caused me to rethink how we do this, and has allowed us to innovate a little bit in this space and find better methods of fixation that require less bone removal and could potentially speed up the recovery process. So I'm in the next few years, I think that we will see that going forward.
That's awesome. And I think it's also going to require a rehabilitation calibration, where if we feel like the surgery is better and it's more efficient, do we have to recalibrate all the physical therapists and ATCs that have rehabbed these over the years to realize that maybe you can move people quicker than you previously have? I'm curious, do you see I know with the ACL research, we know that replacement ACLs tend to be better than the native ACLs, long term, particularly when combined mm-hmm. with a great rehabilitation program. We don't see that with the ulnar collateral ligament right now. The native one is always going to be better. Do you see the day coming when these surgical advances actually make, because we often hear about the parents that come and ask, hey, give my kid Tommy John so he can throw harder. Do we actually see a scenario where we could see a replacement UCL being stronger than a native one?
Potentially. So right now we're not there yet. Mm-hmm. So the native ulnar collateral ligament in isolation. So if you just look at the ligament itself and you put it on a biomechanical machine and you stretch it until it ruptures, it can withstand up to, on average, somewhere around 30 to 35 newtons of force before it breaks. Our most common reconstruction techniques that have been used in the last 5 to 10 years generally tolerate about 20 newtons of force. Mm-hmm. So they're clearly not quite as strong as the normal ligament, certainly better than a torn ligament, but not quite to where the native ligament is. But we've done one of the newer constructs that we've developed. We have been able to test it in the lab, and we were able to get that strength up to 30 to 35 Newton meters, which now approaches what the normal ligament is. So we're still in the early stages of that research, but it's very encouraging and exciting. And I think it's going to have some significant implications for us over the next couple of years.
Yeah. I think one of the things that's interesting when you look at a shoulder or a knee both of those, I mean, if you have a ligamentous injury at one of those joints, you have tons of soft tissue structures that cross the joint. Right at your shoulder, you got more than you can possibly count. There's 17 muscles that attach to the scapula. In your knee, you've got multiple hamstrings, tendons that cross the joint. You've got plenty of active restraints. The elbow kind of gets hung out to dry a little bit more, where you have a flexor tendon that crosses. You've got some stuff that can help you out. Do you think that's ultimately a limiting factor? Is just that you don't have as many active restraints to protect the passive restraints at an elbow?
Absolutely, yeah. So it's really a ratio of the amount of force across the elbow compared to the restraints to that force. And in the elbow, we see that ratio is higher there than anywhere else in the body. And that's because, with a max effort throw, the elbow regularly exceeds that 30 to 50 Newton meters that I spoke of earlier. And so, yes, the ligament itself is not sufficient to keep the medial elbow stable. So it takes all the flexor pronators firing in an optimal fashion. It takes the bony congruity of the joint to provide some stability. So you really have to have all of those different systems functioning in an optimal state in order to maintain elbow stability. And there's really not much room for error like there is in the shoulder and the knee. And that's why I think you can see these guys who just have a mild injury, maybe it's to the UCL or to the flexor pronator mass, really struggle. It's because that is such a fine-tuned system with such a small margin for error that if you introduced even the smallest amount of injury there, sort of the whole thing can kind of fall apart, and it can be tough to rehabilitate and get it back to that optimal form.
And I think on your end too, it can be tough to diagnose, right? If you have ulnar nerve symptoms, that could be because you have an insufficiency of the UCL, you have a flexor tendon that's balled up and nasty, and your ulnar nerve goes right into that. So there's a lot of different variables you've got to consider. And actually that leads to my next question. So ulnar nerve, where's your head at with respect to transposing it with a Tommy John? I know it's dependent on a lot of different factors.
Right.
Do you do it with everybody? Do you do it with some people? When do you utilize it?
Yeah. Generally speaking, for me, I try to leave it alone. There are certain surgical techniques that require you to transpose the ulnar nerve. I'm personally not a big fan of those. So for me, if somebody has no ulnar nerve symptoms whatsoever, I totally leave it alone. I don't expose it at the time of surgery. I know where it is. I protect it. I keep it safe, but I leave it alone. I think it's sort of one of those things. It's sort of best to let sleeping dogs lie. And generally speaking, I think that's true when it comes to nerves and surgery. So that's true all over the body, in the shoulder and the knee and the hip and also in the elbow. So for me, if there's no symptoms, I leave it alone. However, if there are ulnar nerve symptoms, for the vast majority of the population, those are very easily solved by just releasing. There's a band of fascia that goes over the top of the ulnar nerve that can be tight and constricted. It's very easy just to release that. It takes a tiny incision. It's a 5-minute surgery. That works for the vast majority of the population. That doesn't work that well for pitchers. And the problem is, if you release that fascia for pitchers, they then can develop ulnar nerve instability. So then the nerve starts snapping back and forth over the medial side of the elbow, and then their symptoms can actually get worse. So generally speaking, if you do ulnar nerve surgery for a pitcher, not only do you have to release it, but you also have to transpose it and move it up to the front of the elbow in a more secure position. So anytime you are doing something with the ulnar nerve in a pitcher, by the very nature of the activity that they do, you have to do a slightly larger surgery than what you would do in somebody who doesn't try to throw a baseball. So for all of those reasons, I leave it alone unless it's symptomatic. If they're having symptoms, then it's a no-brainer.
And I think sometimes we will see individuals who have ulnar nerve symptoms following a surgery, whether that's transient for a while. I'm curious, different approaches. You obviously mentioned that yours doesn't expose the nerve quite as much. Do you see a lower incidence of post-op ulnar nerve complications with that approach compared to others that are out there?
Generally speaking, we do. So if you look at all over orthopedics and for the medial side of the elbow, if you leave the nerve alone, you're less likely to have issues with it. And so that's sort of the approach that I have taken. But that being said, you can certainly have, somebody who has Tommy John surgery, you leave the nerve alone, they rehab, come back and throw for several years, do great, and then they develop ulnar nerve symptoms down the road. That is certainly always a possibility. That's probably less than a couple of percent of pitchers that can have that, but it certainly can. And there are a lot of great pitchers out there, a couple, without naming any names, some Cy Young winners and some that are in contention for the Cy Young again this year who have had that happen. Had Tommy John, came back, pitched incredibly well. A few years later, ulnar nerve symptoms, had the ulnar nerve addressed, came back, pitched incredibly well again.
Nice. All right, so we're going to backtrack. We're going to talk shoulders a little bit. We hinted at, you don't want a shoulder surgery unless it's absolutely necessary. And I think for a long time they've been viewed in a negative light when it comes to maybe long-term outcomes. I remember seeing some research on like anterior capsule plications in 2012, where you're looking at over 3 years for a return to function if you're going to return at all. So you don't want to have one unless it's absolutely necessary. I'm curious. I don't want to paint with a broad brush and lump all these different surgeries underneath, the same umbrella, but do you have any general guidelines you like to apply to, chronic shoulder pain that you want before you consider a surgical intervention?
Absolutely. Yeah. So I try to keep it clean and have an algorithm in my mind that I use with players. And the first thing that I explain to them, there aren't any high level pitchers that have a normal shoulder. Just, the throwing motion is not the most natural human motion, the overhead throwing motion. And so folks who do that a lot have some normal adaptation of the shoulder. And the most common things that we see are some increased external rotation, decreased internal rotation. There usually is some slight lateralization of the rotator cuff footprint. So that means the edge of the rotator cuff gets just slowly kind of worn away and whittled away. And that creates more room for the pitcher to get up in that late cocking position. So that happens slowly over time. And then also a little bit of blunting of the superior labrum, which accomplishes the same thing. So all of those things are normal adaptations in a pitcher. So we know that if we get MRIs on asymptomatic pitchers, they will have some, quote, abnormalities, end quote. But the key is sort of deciphering which of those are normal adaptations and which of them are actually pathologic things that are causing them symptoms. So for all of those reasons, it's a little bit dicey when you're talking about shoulder injuries in pitchers. Now, things that make it more obvious is if you have an acute injury, you have an acute tear of a structure that's surrounded by bleeding and inflammation, that lets you know that's something new that's happened. That's not a chronic adaptation. And the other thing that's important to remember too, and I think one of the reasons that outcomes after shoulder surgery have not been as good as we would like is because when we repair things surgically, we tend to repair them like they were initially, when somebody was born. We don't repair them to the level of normal adaptation that the pitcher has developed over years, because we don't always know what that is. And I think that is the real reason that the outcomes of shoulder surgery have probably not been as good as what we would like. So we have to take all those things into consideration in the rare instances that we do consider surgery. So getting back to my algorithm and my discussion that I have with pitchers who have new shoulder injuries, I talk to them about trying to separate what's normal adaptation versus what I think is actual injury and pathology. We talk about all the non-operative options. We talk about optimizing their shoulder mechanics, and then we work down the rest of the chain too. We talk about their scapula. We talk about their back and their hips and everything else, trying to optimize all of that so that they transfer energy efficiently to see if we can sort of optimize what happens when that force and energy gets to the shoulder. If we do all of that and they still are unable to get back to pitching, then I think surgery may be appropriate. And so generally speaking, what I tell pitchers is, before we operate on your shoulder, I need you to tell me I cannot throw like I am right now. My chance of getting back to high school, college baseball, professional baseball is 0%. I say, okay, well, in that case, we can do surgery. And, depending on the surgery, the success rate is maybe 60 to 70%, just for instance. So, well, I can take you from 0% to 60 to 70%, but it's still not a guarantee. So that's sort of the discussion that I have. And so before we go into that surgery, we want to be absolutely sure that it is necessary and that there aren't any other options.
And I think, too, it's also a discussion of timelines, right? If you have a 17-year-old kid who might not plan to play baseball after his senior in high school, it's a different approach than if you have a 26-year-old who still has a 7-year big league career ahead of him or something along those lines. So I'm curious about a couple of specific circumstances and what more selfishly for my own reasons, Bennett's lesions. Where's your head at with those? Because we see them. I know there was one study that said we see them in about 40% of major league shoulders, but it's like anything else. They can be little, they can be big, and we sometimes, don't know how to manage them. And I think my classic experience with a Bennett's lesion that maybe has gone underdiagnosed is those are the guys that feel amazing, long tossing out to about 180 feet. The second they get beyond that, or they get off a mound, the external rotation increases and that speed bump, kind of becomes more of a problem. What's your general approach when you see one of those on imaging? How do you attack it?
Yeah. So I think, again, just like the other things I mentioned, that tends to be a relatively normal adaptation in a throwing shoulder that can become symptomatic. And I agree exactly what you said. So the more external rotation they get into, the more likely they are to be symptomatic. The larger ones are more likely to be symptomatic. I think they are there commonly in our throwers if we look for them, but they rarely cause symptoms.
Yeah.
So for me, when I see that, it's going to be the same thing. If I think, well, you're fine up to 180 feet, but beyond that, you start to have troubles. We'll say, well, what happens if you don't? What if you just long toss to 180?
Yeah.
Can you get yourself in shape to be where you need to be? If so, let's do that. If not, then we may consider going in and trimming that down.
Yeah. And is the concern also that, if you leave it alone for too long, that you get more rotator cuff pathology, or is it just the symptoms will always tell you what you need to know?
Usually the symptoms will guide you. So if the player ignores pain and tries to throw through it, then what will happen is they'll start to alter their shoulder mechanics. And you're right. So the humeral head will translate on the glenoid to try to avoid hitting that Bennett's lesion in the back, which then puts stress on the capsule and the rotator cuff and will give them other problems.
Yeah.
So I think it's very critical that they know, if there is pain, you have to pay attention to it. Otherwise, you're going to start changing your mechanics and you're going to cause other problems.
Right on. All right. So I warmed you up with a somewhat easy one, and now I'm going to open the big can of worms on you. The biceps tendon. It's a heavily debated topic in the world of managing throwers. I actually got thrown into this myself. I had Kurt Schilling at the end of his career. He was the first biceps tendinosis in Major League history, 08, 09. So I had to jump into this like crazy. And we got some preliminary research back then, but it was all about how we can use a tendinosis to help out people in the general population who have had failed slap repairs because they've reattached a degenerative biceps tendon, and the outcomes were phenomenal in that population because, unfortunately, they didn't throw baseballs for a living. So, I think we've seen classic slap repairs that may fail because of the tendon quality, where restoring the normal anatomy isn't an option. Where do you stand on that? We have tendinosis as an option. There is, traditional, there's subpectoral, and now we have a biceps transfer surgery. What have you utilized? What outcomes have you seen? Where's your head at on all of that?
Yeah. So you're exactly right. Initially the slap repairs are the superior labral tears. And just to back up too, for those that don't have a medical background, the biceps tendon comes up and inserts on the superior labrum in the shoulder. So we've gone away from thinking of these as either a slap or superior labral tear or a biceps tendon problem. And in reality, I think it's better for us mentally to call these biceps labral complex injuries. It really is sort of one continuous structure. And I think that we fall short of understanding it if we don't recognize that. So we've moved more towards that terminology, biceps labral complex injuries. And then the question is figuring out where along that complex the injuries occurred. Is it just biceps tendon? Is it at the junction of the two, or is it more superior labrum? And historically, superior labral repairs did reasonably well in most patients other than pitchers. Success rates for that surgery for pitchers fell somewhere in the 60 to 70% range. Generally, we like to be above 90%. So obviously there was concern slap repairs were not good for pitchers. So then we thought, well, if we just release the biceps and then fix it, that takes the stress off the superior labrum. We can leave the superior labrum alone. Maybe that'll be a better option. Well, and you're exactly right. In the general population, the success rate of that is, greater than 95%. It's a home run surgery. The problem is in professional pitchers, the success rate for that is around 20% or maybe even worse. So it is very concerning. Now, when talking about this, we have to separate not only the general population from pitchers, but also position players from pitchers. Position players and softball players tend to do much better with superior labral repairs or biceps tenodesis surgeries.
Mhm.
It's really the baseball pitcher is the one that struggles. So in the general population, we've moved more towards biceps tenodesis because it's a faster recovery, higher success rate compared to superior labral tears. That has not been the case in pitchers.
Mhm.
So for me, again, just like I mentioned for other shoulder injuries, try to do everything we can to avoid surgery. That usually involves, rest, modifying activities, modifying mechanics, optimizing everything that we can do in the kinetic chain, rehab, injections, all of those sort of things. If that fails in a pitcher and the injury is isolated to the superior labrum, then I would prefer a superior labral repair.
Mhm.
If it's isolated to the biceps, then a biceps tenodesis. If it is junctional, sort of at that biceps labral junction, then I tend to err towards a superior labral repair in a pitcher, not in the rest of the population, but in a pitcher. And the difference in the success rates there is probably 60-ish, 60 to 70% for the superior labral repair versus 20% for the biceps tenodesis. So that's why I err on that side.
I know one of the concerns with the tenodesis in people who were candidates for it was the risk of humeral shaft fractures with the torsional stress and
Yes.
because they're basically putting that tendon right in a place where it could make you vulnerable, and that was one of the rationales for effectively going to a biceps transfer, which is a newer surgery. I think I've seen two over the last 3 to 4 years. Have you had any experience with it? Do you see that as maybe a next frontier where effectively we're giving them two short heads of the bicep?
Yeah, I have seen that quite a bit, and I worked. Steve O'Brien in New York is one of the surgeons who sort of pioneered that, and
Yep.
I had the fortunate experience to spend a couple years with him when I was training. So I've seen the surgery. I've seen a lot of it, and I think that it is a great option. One of the other things, though, as he was developing that, as that was coming out, one of the other things that had happened, similar to what I mentioned for the elbow, is that our technology in our anchors and fixation devices have also improved dramatically. So the previous concern with the fractures in the humerus tended to occur when people were putting large holes and large anchors in the humerus to fix the biceps. So some of these were 7, 8, 9 millimeters in diameter, which is a fairly large hole in a bone. Now we have moved to much smaller anchors that still give us robust fixation. So generally speaking, now some of the anchors we use are on the magnitude of 1 to 3 millimeters in size. So it has dramatically reduced the size of the hole that you have to make in the humerus. So for that reason, I think that it's the transfer, although is valuable, I do think doing a standard tenodesis is a reliable option now because we're able to make such a much smaller hole, has a less likely risk of fracture.
I think the other thing that I think about with that is maybe an intriguing discussion point is anytime you're fundamentally changing anatomy even more significantly when you shift it over onto that coracoid process. I actually saw an athlete, believe it or not, who had a biceps transfer and then years later had a thoracic outlet surgery with a pec minor release. So you almost have to wonder, did that extra short head of the biceps pull him into a little bit more anterior tilt that subsequently had to be released in a different avenue? So we're playing with what God gave them, and it makes things interesting.
Yeah, absolutely.
So I think one of the things that I and this is shifting gears a little bit, maybe going back to the discussion of shoulder injuries going down as elbows go up, but you've done some really good descriptive research that focused on the concept of regional interdependence, i.e., stiffness, at one joint can create accessory motion that's excessive at an adjacent joint. I say some of these examples. In 2018, you looked at preseason limitations to hip and turn rotation, and they were associated with an increased risk of low back and abdominal injuries in professional players in the season that follows. And then in 2017, which honestly one of the most important studies I think we've seen in recent baseball research, you and your group reported that limited shoulder flexion and shoulder external rotation were associated with a significant risk in elbow injury. I think it was a 2.83 times increased risk of injury to the elbow in the season that followed if you had more than a 5-degree shoulder deficit as compared to the other side. That study also demonstrated that maybe glenohumeral internal rotation deficit isn't as significant as maybe we've discussed over the years. So, all this data in mind, what range of motion measurements are the ones that you place the most value on when a 18-year-old kid with shoulder or elbow pain comes into you? Are there any things that you haven't formally researched that you have speculation in your mind have big implications for keeping throwers healthy?
Right. Yeah. I learned a lot from doing both those two studies that you just mentioned. And in reality, we were doing those studies sort of looking for causes for elbow injury.
Yeah.
And I had anticipated or hypothesized that for that first study in 2017, that reduced shoulder motion would increase the risk for both shoulder and elbow injuries. But that wasn't the case. It actually had no effect on shoulder injuries. It just had an effect on elbow injuries. So it was almost sort of that kind of next link in the chain, as you mentioned. So what we have found is that it does seem as though it doesn't necessarily affect that joint itself, but can have implications on the subsequent joint. So that has sort of allowed me to kind of rethink how we approach this, and that anytime I'm seeing somebody with an elbow injury, yeah, you want to look at the elbow, but you need to go back one joint as well, at least one joint, if not more. So anytime we have an elbow injury, I'll also want to look at the shoulder. And I think you're right. We paid a lot of attention to GERD and internal rotation deficits in years previous. But ultimately, I think what we find, if you take all of the literature that's been published on that in summation, it's very clear that it's not as simple as GERD.
Yeah.
So some of the studies have shown GERD's a factor. Some have shown that it's not. It's certainly more complex than that.
Yeah.
And generally speaking, it seems that if a player has internal rotation deficit, but they have the increased external rotation to make up for that, and they've maintained their total arc of motion, they may not be at as big a risk for injury. So it's probably more that total arc of motion that matters rather than just the internal rotation deficit. Because simply what these pitchers end up doing is they basically hopefully can keep the same motion. They just shift it externally. They just sort of shift the whole range. And some of that comes from normal adaptation over the years. You can get humeral torsion or rotation of the humerus that develops in the bone itself if they throw a lot when they're young. That is not going to be able to be corrected by stretching. And so I think it's important to recognize that it's not all about GERD and it's not all about sleeper stretches, that there's more to it.
Yeah.
So for me, to answer your question more specifically, I think the most important things to look at in the shoulder is total motion. And then also two things that I think are underappreciated is simple forward flexion. We've shown that lack of forward flexion can cause injuries. And then I think horizontal adduction across the body is also important too, which may be a better marker for posterior capsular tightness than internal rotation. So for me, it's a total motion forward flexion and cross body adduction, which I think are very, very important.
And I think the unifying trend with limited shoulder flexion, limited external rotation is extensibility of lat, right? So right as we're seeing more and more athletes, tear lats / teres majors, we're also seeing more thoracic outlet, which could be related to like a large muscle like a lat having a gross depressive impact on the entire shoulder girdle, pulling that clavicle down indirectly through the scapula. I think it comes back to, like, if we can get good extensibility through the lat, we could probably get cleaner flexion and external rotation, and we probably get what we would consider like a true shoulder external rotation, an actual layback, as opposed to asking that hinge joint to pick up the stress with more valgus.
Right. Yeah, I agree. And really what you're highlighting here is that it isn't just one measure or one muscle. I mean, to function at the level that our athletes desire, we need to optimize everything. It's just like a race car. You've got to have everything tuned up. Your oil has to be changed. You've got to run the best gas. Everything has to be perfect for optimal function.
What are some areas where you think we need to look more? Like, is there, you mentioned the things that keep you up at night. I know I have things at 3 a.m. I stare off into blackness thinking about. Are there any measures that you think are the next frontier?
Yeah, in terms of motion.
Yeah.
I think part of it is turning our attention down to lower segments in the chain.
Yep.
We spend a lot of time studying motion in the shoulder, which we now know is important to all of these different motions. But I think next is looking at lumbar mobility, hip mobility, and even knee biomechanics and those sort of things. I think all contribute. We found in the 2018 study you mentioned, we were looking at hip rotation because we thought that might have some implications for elbow injuries. But it turned out that it was more strongly correlated with low back and abdominal injuries, which we know are rampant in professional baseball. It's such a rotational sport for both throwers and hitters. And if they're not getting that rotation through the hip, all of that, that whatever force and energy, it doesn't come through the hips, goes through the core. core musculature in the low back, and then they're at high risk for injury there too. So we have to not just have tunnel vision on the shoulder and elbow. We've got to look at the rest of the chain as well.
I think you even, in your research, you also hint at, it's a hackneyed expression that our staff calls it a Cresseyism, but small hinges swing big doors. In that study where you looked at preseason shoulder range of motion, the risk of elbow injury increased by 7% for each degree of increased shoulder external rotation deficit. So we're dealing with a scenario like that. That shoulder is a very tightly controlled joint, right? A lot of people believe that impingement is a physiological norm. So every degree matters for a lot of these athletes. And I think that's a good lesson for, not just the folks in your world who are diagnosing, but also the clinicians who are doing these assessments. It's important not just to be, accurate, but it's also important to be reliable so that you can look at the same athlete 6 months apart and really differentiate whether things are changing.
Right. And for those I agree, Eric. And for those reasons, we also have to be precise in our measurements too, and what we're talking about. So these need to be better than just estimates. We really need to pay attention to these measurements, try to do them well, do them accurately, be consistent so you can make some meaningful changes and you can measure that change.
Yeah. And I think the other thing that is an important consideration as well is, all these numbers that we've talked about, these are very osteokinematic in nature, right? We're talking about shoulder flexion and internal and external rotation. There's a large arthrokinematic aspect of this, is that we can't just look at range of motion. We have to understand how strength, proprioceptive capability, these things allow us to, control a joint like the shoulder, which is controlled in such a tight window. So I'm curious now. So what's in the pipeline for you now? I know you're super active. The list goes very, very long on PubMed when you search by your last name. What are you looking at next in your research endeavors?
Yeah, a few things. So one of the things, as I mentioned earlier, we're still sort of optimizing surgical technique for Tommy John, which is something that I'm really excited about, and we've had some very great initial success with a new technique that we're still studying. So that one's near and dear to my heart right now. We'll see how that goes over the next year or two. The next big thing that I'm really interested in looking at is individualizing the rehabilitation process. Right now we have, there are a lot of great throwing programs and protocols out there. And to the best that we can, we have based these on data and evidence. But the problem is most of them sort of have a one-size-fits-all approach. And I think that we now have enough information and data that we can be smarter than that we don't have to have every thrower doing the same thing and trying to progress through the same program.
Yep.
And in reality, all of our throwers, they're built differently. Their mechanics are different. Their goals are different. And so for those reasons, we really need to start individualizing things. And it doesn't make sense if you've got a high school pitcher who had Tommy John, who maybe, let's say, is throwing 82, and their goal is to throw 60 innings a year, rehabbing with a professional next to a professional player who's throwing 98, and their goal is 200 innings a year. Should those two throwers be on the same throwing program? I mean, the obvious answer is no. But how do we individualize it? And so I think what we need to do is understand individual mechanics, individual forces in our throwers, and can tailor a program to them, because we want to accelerate them through a program as fast as we can without causing undue stress to the ligament or whatever it was that was fixed. And there may be some throwers who are so efficient in their mechanics that the ligament or shoulder or whatever it is sees very little stress, whereas others who have poor mechanics for whatever reason are seeing an excessive amount of stress. Well, we should not penalize that efficient thrower by holding them back to the average throwing program, and we should not put the inefficient thrower at risk by trying to make them do something that their body's not designed to do. So we need to individualize that so each can sort of advance through that program at a pace that is more appropriate for them.
That's outstanding stuff. All right, so we've taken enough of your time today. This was outstanding. I actually have a page of notes written right here. I learned a bunch, and I'm sure that a lot of the folks out there, from all walks of life, have as well. Where can folks learn more about you, Christopher?
Yeah, great question. So, feel free. You can look up some of the research that we've done on PubMed, and then also, I work at the Mayo Clinic, which is where I see patients and do surgery. And our website is sportsmedicine.mayoclinic.org. So feel free to take a look on there. And some of the stuff we talked about is on there, plus a lot of other stuff. So you can see our team and there are different ways, our contact information and everything. If you need to reach out or make appointments is all available there.
Absolutely. I'm going to give you a shout out. Your Twitter account is outstanding. It's at Chris Camp MD. And you are, no, seriously, it's an excellent source for, up-to-date research, in the throwing community and beyond. So that's an excellent follow for a lot of the sports medicine folks out here who want to stay on top of stuff. So we really appreciate you taking time. This was outstanding.
Well, thanks so much, Eric. I appreciate it. You've given me more motivation. I have a love-hate relationship with Twitter. So if you find it's helpful and you like it, maybe I'll keep going. So I'll keep trying to add good stuff for the world out there.
Keep fighting the good fight. We appreciate it. And thanks so much for coming on, Christopher.
You got it, Eric. Thanks a lot.
Take care.
Thank you for joining us for another episode of the CSP Elite Baseball Development Podcast. If you enjoyed this episode, we'd be thrilled if you'd consider subscribing to the podcast and leaving us a review to read on iTunes. We welcome your suggestions for future guests and questions. Just email elitebaseballpodcast@gmail.com. Thank you for your continued support, and we'll see you next episode.